I am Professor Atul Goel. I am head of Department of Neurosurgery at KEM Hospital, and we have a public hospital where we cater. Our services are completely and entirely free of cost for the patients. Chiari malformation, syringomyelia, basilar invagination, craniovertebral junction anomalies that involve short neck, torticollis, rotation of the neck, and various other malformations that are related to these issues are extremely complex clinical problems. They are not only complex anatomically, but also biomechanical issues are quite intricate and controversial. And also technical, because of the deep situation of the craniovertebral junction, critical nerves and arteries in relation to the area, and extensive blood loss during surgery are very important issues that have to be really understood properly and executed 100%. This is because any kind of complication in surgery can be devastating for the patient and for the relatives. On the other hand, good and successful treatment has a potential to give complete new life to the patient and to the relatives. Chiari malformation and syringomyelia are worldwide issues. There are societies of Chiari malformation, society of syringomyelia all over the world, where they cater to a number of patients, and the numbers are huge. So the subject has very big implication as far as the clinical treatment of these patients is concerned. So what I am going to talk to you is basically how Chiari malformation, syringomyelia, and basilar invagination, and many of these anomalies are related to instability of the craniovertebral junction, and how the treatment of instability can completely change the existing treatment protocol of these problems. Basically, our department has been known worldwide as far as the treatment of craniovertebral junction is concerned. We have the largest numbers in this field, and I will relate to you as to what our personal contribution on this subject are. Craniovertebral junction, as I mentioned to you, is a very complex subject, and 100% understanding of the subject is mandatory. You cannot have half information and work on it. You cannot have incomplete understanding, and you can land into very serious and severe problem if you don't understand this subject 100%. So I want to give a smallish kind of a summary of the region and what our personal understanding is. This understanding is based on a large number of publications on the subject, which may be more than 200 publications we have done in the last several years. And as you can see in this paper, basilar invagination, syringomyelia, Chiari malformation, these are related pathogenetically or to atlantoaxial instability. It means that atlantoaxial instability is the cause of these problems. This concept is non-existing in the world, but our experience suggests that if we have this understanding that atlantoaxial instability is the nodal point of pathogenesis of this subject, the treatment can radically and revolutionary implications can happen with this understanding. Craniovertebral instability is quite a subject, and this is another paper on this subject. As you can see in this slide, this person has got quite a complex neck rotation. More than neck rotation, he was symptomatically or neurologically quite devastated. He was not able to sit or stand, and he was hardly able to move his limbs. But following surgery, his neck has returned significantly into normal position, and he can function quite normally, and you can see the happiness on the faces of their family and his personal happiness. He has essentially got a completely new life. This is another very complex problem where the neck has been rotated and the gentleman is not able to even look forward, and more than that, he has severe neck pain. All these things have completely devastated this human being, to the extent that this healthy young farmer was led to begging, and he could not even sit down and beg, because for begging he needed to keep his head ahead and front, so he could not move his limbs, and begging was difficult, pain was a problem, and the whole family left him. The entire friend circle devastated him completely and left him. So this person was in a severe problem, and we treated him to the extent that he has now got new life. So essentially what I mean to say is, there is a potential to give new life. There is a potential to completely change the outcome of the human being and his family. And what is more important and what is more critical is to understand these problems, understand the basis of this problem, and then execute it to the perfection. You see, just understanding is not enough. Execution to perfection is necessary, because as I mentioned, less than perfect handling, less than perfect execution may not be successful. So that is what are the issue. As far as the craniovertebral junction is concerned, the entire subject has revolutionized in the last 25-30 years with the introduction of computer-based technology and imaging. So this investigation, plain radiology or plain X-ray, was the only investigation for several years, more than 100 years. This was the only investigation that existed. And dynamic flexion extension imaging was the mode of doing this investigation. And on the basis of dynamic imaging, all kinds of diagnoses were made and the treatment was executed. However, you see this image, it is showing a 3D model, and this model we can hold in hand. Where is that model? We can now hold the model in our hand and then analyze the anatomy of the subject area which is in question, and then we know the anatomy of the various complex and critical arteries, which is the vertebral artery in this area, and this is the model that I am showing you. This is a model of a patient. We can actually, this is a life-size model. The bones of the patient and this model are exactly of the same size, and we can see during the operation, we can keep the model right by the side. We can see where the vertebral arteries, where the facets are, and where we have to put the screws and how we have to put the screws. And this kind of advanced technology, you will be happy to learn that we were the first one in the world to introduce this technology for the world, and our paper was published on this subject as to how this 3D model can completely revolutionize the treatment of craniovertebral junction. So this is my paper which is mentioning that 3D models and how this technology has emerged into the world of craniovertebral junction. So what essentially I am going to talk to you, and what we have changed the treatment in that perspective about, I am going to talk to you about basilar invagination, about Chiari formation, and about syringomyelia and their relationship with atlantoaxial instability. I must let you know that understanding of this implication, understanding of these problems and their relationship with craniovertebral junction instability has huge implications in the treatment, and it can completely change the existing format of treatment. So this is one slide which is showing you the Chiari malformation. This is Chiari formation and this is syringomyelia. And this is a very common kind of image in the world. Not very common, but very frequently seen, and has implications in the treatment. This is another slide showing basilar invagination, syringobulbia is here, and syringomyelia and Chiari formation or malformation. Here this slide is showing basilar invagination. This is basilar invagination, there is Chiari formation and syringomyelia. So basilar invagination, Chiari formation and syringomyelia, this is a common clinical triad. Common basilar invagination, Chiari formation, syringomyelia. This is a common triad. Of course, basilar invagination may not be present in all the cases, but it is present in several cases. Here in this slide, you see there is a manifest atlantoaxial instability. Atlantodental interval is increased, so it is showing that there is atlantoaxial instability with Chiari formation. This manifest or present instability is not always there. Now you see this slide, it is showing Chiari formation, it is showing syringomyelia, and there is no bone malformation. There is nothing, there is no abnormality as far as the bones are concerned. So Chiari formation and syringomyelia can be present when there is no bone formation, malformation. And such an anomaly, where there is Chiari formation and syringomyelia, is more common in Western world. In the Indian context, basilar invagination is a more frequent presentation. But also even in India, Chiari formation and syringomyelia is present without any bone malformation. So bone malformation, present or not present, is an issue. The question comes when there is basilar invagination and when there is no basilar invagination, whether the Chiari is different, whether the syringomyelia is different, or whether it is the same, whether the treatment in presence of bone malformation is different or whether it is not different. So this is another very big question in this subject. As far as the treatment of Chiari formation is concerned, it is highly controversial, and to the extent that every surgeon in the world treats this problem in a different fashion. Some people do foramen magnum decompression or craniectomies in the suboccipital region. Some people do C1 laminectomy, some people do C2 laminectomy, some people do tonsillectomy, some people open the dura, some people keep the arachnoid intact, some people do tonsillectomy, some people introduce shunts for syringomyelia, some people like to do bone implant for stabilization or for supporting the cerebellum. So the problem is, and the issue is, that the treatment is so much different. The basis of this difference in treatment for every surgeon is because the understanding of the pathogenesis of Chiari formation is not clear. Everybody knows how to treat Chiari formation, but nobody in the world actually knows what is Chiari formation and why it happens. The problem is, it is called tonsillar herniation sometimes because it is associated with tonsillar herniation. Chiari formation is actually tonsillar herniation. This word herniation has created the controversy because whenever you talk about herniation, you relate it to uncal herniation or temporal brain herniation. Because temporal brain herniation is such a dangerous issue, you also think that tonsillar herniation is a dangerous issue. Because you think temporal herniation is a highly pathological issue, you think that the tonsillar herniation is also a pathological issue. So we had written this article in 2014. The title of this article is Atlantoaxial Instability the Cause of Chiari Malformation? See, this title has huge clinical implication. Huge means it has the potential of completely changing the existing treatment. So in 2014 we had written this. It implies that Chiari malformation is due to atlantoaxial instability. And atlantoaxial fixation is the treatment of Chiari formation. It also means that whatever the treatment was existing, like what I mentioned now about foramen magnum decompression and C1 laminectomy and C2 laminectomy. Whatever treatment has been existing is not correct, or it has to be changed. So it has quite a big implication. So 2014 we published this article, and after 2014, in the further 4 years, we have got a very big experience of this problem, and our results are so fascinating and satisfying that there is no controversy in our own mind that this is indeed the problem, and stabilization is indeed the treatment of Chiari formation and syringomalia. The other very important issue that we have introduced is the concept of central or axial atlantoaxial instability. It means that the existing current radiological parameters are not sufficient enough to identify instability of the craniovertebral junction. Currently, atlantodental interval problem is the only parameter in the world on dynamic imaging which suggests presence or absence of atlantoaxial instability. However, even in the presence of normal atlantodental interval, even in the presence of normal facetal alignment, the atlantoaxial region can be unstable. If you understand this this issue of central or axial atlantoaxial instability, the entire treatment format for Chiari formation in general, but there are other issues like basilar invagination and syringomalia can be completely and entirely changed. Also, it can have implications in the treatment of cervical degenerative spine, in the treatment of OPLL, in the treatment of Hirayama disease, and in the treatment of several other very commonly encountered clinical conditions. So this is another issue which I will like to discuss. As far as the spine is concerned, it is like a pillar and it bifurcates. It bifurcates. This bifurcation of the pillar is the craniovertebral junction, this upper bifurcation. And this is the pillar. This bifurcation has two joints, atlantoaxial joint and occipito-atlantal joint. Occipito-atlantal joint is the most stable joint of the body, occipito-atlantal. And atlantoaxial joint is the most mobile joint of the body. So mobility and stability are the hallmarks of craniovertebral junction. Mobility by atlantoaxial joint, stability by occipito-atlantal joint. These two joints form the craniovertebral junction. As far as I am concerned and my understanding goes, occipito-atlantal instability is extremely rare, and it is present in high degree of trauma or in some pediatric syndromal issue. Otherwise, occipito-atlantal instability can never happen. On the other hand, the most mobile joint is atlantoaxial joint is very liable, or very frequently there can be atlantoaxial instability. More the mobility, more the potential of instability. This is the concept. So atlantoaxial instability is a very commonly encountered subject, and I can also say that it is very much or underdiagnosed clinical problem. If you diagnose atlantoaxial instability on a very more frequent basis, you can treat many other problems which we are not treating properly or adequately at present. So this is the atlantoaxial joint. You see why it moves so much? Because it is flat and round. It is flat and round. And because it is flat and round, this is the atlas. This is the atlas vertebra, and if you see, it is flat and round articulation. Because it is flat and round, it provides you a possibility of moving circumferentially like that. All other joints like hinge, this is a hinge joint, this is a ball and socket joint, it stops here. Hinge joint, you cannot move sidewards. But this joint has a potential of saying yes, no, round, everything. So this joint is the most mobile joint of the body. And also this joint because of its flat and round nature, has the most high potential of becoming unstable. This is the concept, that it is most mobile, but it has the potential of becoming stable more often than any other joint in the body. And this is the facets form the fulcrum or the center point of the movement of the atlantoaxial joint, fulcrum of the joint. The movements occur at the fulcrum and they are executed by the various muscles. Okay, various muscles. So this C1, C2 has the spinous process of the C2 is the largest spinous process in relative terms in the entire body, largest. And also the C1 transverse process is the largest in the whole body. So this C1 transverse process gives rotatory movements, this movement, rotatory movements. And this movement is in addition to rotatory movement, flexion, extension, all kinds of movements because of the C2's large spinous process. You see, C2 transverse processes are very small. You see, there is hardly C2 transverse process. On the other hand, C1 transverse process is huge. So these 2 points are very important, crucial points of the pulley. They pull like this, and the movements are executed at the facets. Facets are the fulcrum of the movements, that is number one, and also the facets are the point of instability. The instability occurs here. So that is the issue. So if the instability occurs at the facets, the treatment of instability also has to be at the facets. You understand? So we in 1988 we described this C1 C2 facetal fixation. One screw in C2, one screw in C1, open the joint, introduce bone graft in the articulation, and then do fixation. So this technique of ours, which we described in 1988, about 30 years ago, is now the number one technique of fixation of the atlantoaxial joint in the world. I can say very clearly and without any doubt that all the leading departments of craniovertebral junction surgery, who are doing craniovertebral junction surgery, are performing this technique. Still, this technique, because of the difficulty in performance in this technique, they might opt for suboptimal kind of fixation. But everybody knows for sure that this is the ideal technique or the optimum technique of C1, C2 fixation. And this technique, these 2 articles which I have mentioned here, are the most highly cited papers in technical spine in the world. In the top 100 articles, these 2 articles feature very prominently. So this is a very well-known technique in the world. So my technique involves opening of the joint, removal of the articular cartilage, stuffing of joint with bone graft, and then performance of the metal implant. So in 1988, we also described the C2 nerve root or the C2 ganglion, which comes right in front of the joint. If you section this ganglion, we can easily expose the C1, C2 facet joint and perform this operation. We mentioned that understanding of this fact, that you can easily cut the C2 ganglion and expose the C1, C2 articulation, has completely revolutionized surgery in this area. This is very critical. Of course, we don't perform C2 ganglion sectioning in all patients recently, but only to understand that this is possible and this is without problem has huge implications in the surgical treatment. So what I am going to now talk to you is how we came to the conclusion that Chiari formation and syringomyelia and basilar invagination are related to atlantoaxial instability. So this is, I am going to rapidly summarize these issues. We also describe for the first time in the literature occipital screws. occipital screws, fixation of metal plate by occipital screws. But now we are saying that inclusion of the occipital bone in the fixation construct is not necessary. We are also saying that fixation of the occipital bone in the fixation construct is a negative operation or a harmful operation, and it provides less than optimum kind of stabilization of the region. So we are saying that occipital inclusion is not necessary almost in 100% of cases. We are saying that craniovertebral junction instability is atlantoaxial instability. Craniovertebral junction stabilization is equal to atlantoaxial stabilization. Occipital fixation is negative, harmful, and less than necessary operation. So is inclusion of occipital bone necessary or counter-effective? I have no controversy in this, that it is a counter-effective or a negative operation. And I have already mentioned, and clearly and definitely, that if you have to do craniovertebral junction surgery, you have to do it 100%. If you are not able to do 100%, don't touch it, because any kind of negative implication for the patient can be very, very harmful. So in 1998, that is about 20 years ago, we published this article, which is also amongst the highly cited papers in the world of spine and amongst the top 50 papers in the world of craniovertebral junction surgery. Has been cited more than 350 times in Google search. We suggested a classification of basilar invagination in 1998, where our concept was that basilar invagination is related to compression. And in basilar invagination, atlantoaxial instability was not instability, it was a fixed problem. Atlantoaxial joint was fixed. So that was the concept in 1998. And we introduced this concept that basilar invagination should be treated depending on how the basilar invagination is. But the problem was, the issue was, atlantoaxial joint was fixed. That was our understanding. And decompression was the treatment. You understand what I am saying? Decompression was the treatment in 1998. So we divided basilar invagination into two types, as you can see in this slide. In the first slide, odontoid process is going inside, and in the second slide, the Chiari formation is coming downwards. So there are two types of basilar invagination. The whole complex in the second type is going rostrally. So in the first type, transoral decompression was the treatment. In the second type, foramen magnum was the decompression was the treatment. So decompression was the treatment. In the first type, transoral. In the second type, foramen magnum decompression. And we said that foramen magnum decompression is a good operation. And we also said that the posterior fossa volume is small in cases of basilar invagination and Chiari formation, and we did a study on basis of 180 or 90 cases, and for the first time in the literature we said that there is no need to open the dura in this situation. However, as we matured in the business of craniovertebral junction, we learned the art of manipulating the atlantoaxial joint. And we came to a conclusion that some of these cases with basilar invagination, atlantoaxial joint can be mobilized and the basilar invagination can be reduced. So this article, which was published as cover page of Journal of Neurosurgery, before 2004, transoral surgery was a very frequently performed surgical treatment. Our article on this subject, where we mentioned that basilar invagination can be reduced in a select group of patients, like this was a fixed atlantoaxial instability. we considered it fixed, and the whole world considered it to be fixed. So in this situation, transoral decompression from the mouth was the treatment. But opening of the joint, distraction of the facet can reduce fixed atlantoaxial dislocation. This was the concept that we introduced. We also introduced this concept of manipulation of the facet, which was absolutely important for some such cases as you see in this slide, where the facets are completely in a different direction. You can open the joint, manipulate the facet and bring them into alignment and then fix. So manual manipulation as a form of treatment was introduced by us. Rotatory dislocation. The rotatory dislocation as a clinical entity has been identified for several years or several decades, but nobody in the world knew how to treat this problem. But the introduction of our technique of manual manipulation has completely introduced a new form of treatment for these children, and you can manipulate the facet and bring rotatory into alignment. Vertical dislocation, we introduced this clinical entity, vertical like a piston. Do flexion, it goes in, do extension, it goes out. So this is also a new entity which we mentioned, that without manipulation, without the change of atlantodental interval, vertical instability. You see in this slide how the odontoid process is going up in flexion and how it comes down in extension, and see the neck size. So in 2004, our treatment changed partially. We said that where we needed transoral surgery, where we said earlier, where we needed transoral surgery, you do open the joint, distract the facet and do craniovertebral junction realignment and bring the odontoid process down, and in the process also fix. So we introduced the factor of instability in the treatment of craniovertebral junction and basilar invagination in a group of patients in 2004. Did you understand what I'm saying? However, in group 2 basilar invagination, which we had said, we still recommended foramen magnum decompression in 2004. Now this is one case where there is severe basilar invagination. We recommended that you do, there is no need for transoral decompression, you do distraction, and you see how this was a very clear case for transoral surgery and decompression, but we said there is no need for decompression in these patients, you distract and reduce. This is another case which you can see that there is a basilar invagination, you do distraction, reduction, fixation. Over the years, over the last several years, we have got a huge experience in these problems. In 2017, we did 200 cases in 1 year. And over the years, we have done C1, C2 fixation in more than 2,500 cases, which is without any doubt a huge experience. Nobody in the world has even experience of treating C1, C2 of 200 cases. So we have quite a remarkably huge experience in this problem. We also introduced these spacers. These are intra-articular spacers, which we said that you distract and introduce these spacers, and these spacers can keep the odontoid process in position for a period of time till the time fusion occurs. Of course, over the period, we don't use spacers in every patient. Our indications of use of spacers has remarkably reduced, and we have only select group of patients where we use spacers. So this is the use of spacer that we are mentioning, and atlantoaxial instability treated by spacer, and you can see the bone fusion which has occurred in a very defining fashion. So we said that these patients where these cases of basilar invagination where we said we can reduce are related to instability like lumbosacral listhesis. If you see in this slide, like lumbosacral listhesis, there is a C1 over C2 listhesis. Like you treat lumbosacral listhesis, you treat C1, C2 listhesis or basilar invagination. So this was also quite an original concept. We also realized in 2005, this article, that there are some patients of Chiari formation and syringomyelia where there is a listhesis or C1 over C2 facetal listhesis, as you can see in this slide. And this listhesis is the problem, and you can do facetal distraction, reduction of the craniovertebral junction, and you can actually do realignment. So we had said that there are some patients with Chiari where instability is the issue, distraction reduction is the treatment, 2005. But I must also say, in similar situation in 2005, our treatment was foramen magnum decompression in 2004, 2005, 2000 and further few years. As we further matured in the business of craniovertebral junction, we realized, like in this slide you see that there is a tumor and Chiari formation. So we are saying tumor is the problem, Chiari formation is secondary issue. We have now realized that Chiari formation is a secondary issue invariably. Chiari formation is never a primary problem. This is a huge statement in the treatment implication for the subject. We had also said that syringomyelia is never a primary issue, it is always a secondary issue, it is not a pathological phenomena, it is not a harmful phenomena, it is a helpful and a natural divine phenomena meant for the treatment of the problem, not for harming the patient. So these are some of the publications where we have mentioned that syringomyelia is not a problem, it is a natural protective phenomena. The other very crucial and important article of ours which says that these short neck, torticollis, kyphosis, platybasia, Klippel file abnormalities are not primary problems related to some embryological dysgenesis or some during fetal life, some problem. These are not problems. These are secondary to one issue, and that issue is atlantoaxial instability. You stabilize the atlantoaxial joint, there is a potential for neck to become long, the neck to become straight, the bone fusions to unfuse, the platybasia to reverse. So the issue, this article of mine, where we are saying that there is a potential of all these problems to reverse, and there is a reversal of these long-standing musculoskeletal problem is possible by treatment of atlantoaxial instability. You can imagine that the entire world was considering short neck as the primary problem, and because of the short neck odontoid process is going in, this was the existing understanding. Now if you are saying that atlantoaxial instability is the problem, spasm and short neck are secondary issues, protective issues, and odontoid process goes secondarily. If you distract, the odontoid process can come down. If you fuse, the whole anatomy can re-change into normal. So this article has a revolutionary impact in the understanding and treatment of these problems. So if you see this slide, you can see there is a short neck, and after the surgery it has become long, and also it has become straight. So we have got several children like this where the neck has become straight. It is not just the neck which is the issue, it is the limbs and the problems in the hands, shoulder pain, neck pain, body pain, inability to do, perform, to walk, and to have various clinical problems. The issue is you treat them properly, you give new life instantly and in the evening of operation. So this is a complete neck is on the other direction, and after surgery it can come straight, and it can come straight and look at you. So you give the power to the patient in the hands and leg, and you give them potential to look straight and forward without worry. So we had this understanding that atlantoaxial facetal listhesis is the problem in a select group of basilar invagination. This was the understanding in 2004 and 2005 during that time. But we matured, we understood more and more this subject. Before I go to that, in this slide you see there are so many bone fusions. You can see spina bifida, C1 bifida. So we have said that bone fusions are not primary issue, they are secondary and protective phenomena. Spina bifida is a dynamic phenomena. You do flexion, it opens. You do extension, it closes. So close, open, close door kind of phenomena. You do flexion, extension, close, open. So this bifida is not a negative process. It is not a embryological complication or a problem. It is a protective phenomena. It is meant to help the person. So you do flexion, extension. So it is a natural kind of decompression or a natural laminectomy rather than a negative phenomenon. So all these things which I am mentioning about natural protection and all those things and open close are mentioned in this article which was published in the journal Neurosurgery. This is another case where we have introduced. So here comes in 2012. So I said about 1998 that we thought that the whole process is fixed in 1998. In 2004 we said that some are fixed, some are not fixed. So where they are fixed, you do decompression. Where they are not fixed, you do distraction, reduction and fixation. This is what mentioned. In 2012, our understanding completely changed. Our understanding changed where we now started talking that whether or not in all cases of basilar invagination are unstable and you need to do atlantoaxial fixation. So we changed from fixed to partially fixed to completely unstable situation, and we mentioned here in this article that atlantoaxial instability is the cause of basilar invagination in group 1 and in group 2. And we did atlantoaxial fixation with or without the presence of basilar, without the radiological demonstration of atlantoaxial instability. So if you read the title of this article, for basilar invagination without any obvious atlantoaxial instability, where in the past we used to do foramen magnum decompression. So we now mention that foramen magnum decompression is not necessary. We now mention that foramen magnum decompression is actually harmful. We had described foramen magnum decompression on the basis of small posterior fossa. We had said don't open the dura. Now we say no need to do decompression. We had described occipital screws. We say we should not do occipital screw fixation. Now we are saying foramen magnum decompression is a negative operation. It is a harmful operation in the long run, not required. So we have several articles on this subject where we are discussing about treatment of basilar invagination in various kinds of group A, group B, and the treatment is only one. Treatment is atlantoaxial stabilization. Atlantoaxial instability is the problem. Atlantoaxial stabilization is the treatment. We introduced a new classification of atlantoaxial instability on the basis of facetal malalignment. As I mentioned, the only one parameter that exists even today for several people in the world, I will say for everybody else in the world, atlantodental interval. You do flexion. If the atlantodental interval increases, it is unstable. If there is odontoid process related compression of the brainstem, it is unstable. Now I am saying whether there is compression or not, whether the atlantodental interval increases or not, we are dealing with an unstable situation, and we can identify this instability on the basis of facetal malalignment. And if you see this slide, you can see the facet of atlas is in front of the facet of axis. This was our earlier discussion, and if you see atlantodental interval is increased. If you see this slide, there is a huge basilar invagination. You see there is a huge basilar invagination. There is no problem in atlantodental interval. but the facets are in malalignment. And these patients do not need anything else, but they need atlantoaxial stabilization. So this stabilization can lead to complete reversal of various neurological symptoms and problems. And this is another case. If you see, there is Chiari formation, syringomyelia, and the facets are under malalignment. The facet of C1 is behind facet of C2, and you do only fixation, the syrinx can reduce in size. This is another case of basilar invagination. There is no atlantodental interval issue, but the facets are under malalignment, and this is I have called type 2 atlantoaxial instability. Atlantoaxial stabilization is the treatment. This is another case. We now introduce another issue, that whether the facets are in alignment or not in alignment, the atlantoaxial joint is unstable. So we call such an issue as a central or axial atlantoaxial instability. Whether the facets are in alignment or they are not in alignment, these patients need atlantoaxial stabilization. So that is the concept. You see, this is another patient. There is Chiari formation, and there is no facetal malalignment, and the treatment is by atlantoaxial fixation. We have now several examples which goes in hundreds about what I am saying and what we have treated, and this is one of them. If you see preoperative slide showing Chiari formation. So why I am using the term Chiari formation? Because I am saying that Chiari is a natural protective phenomenon. It is not a malformation. Syringomyelia is also a natural protective change in the body. And you do fixation, and you see immediate post-op syringomyelia can reduce, and delayed, of course. Earlier in my experience and also in my articles, I had mentioned that syringomyelia reduces in about 30% of patients. But today I am saying syringomyelia reduces in 100% of patients in a long-term basis. After 1 year, all patients with pre-operative syringomyelia, 100% of patients, the syringomyelia size will reduce, and that is there is no question. Whether the syringomyelia size reduces or not reduces, whether the syringomyelia changes or does not change is not an issue at all. What is an issue is whether the patient recovers or not, whether the patient improves in the symptoms or not, and there is no question, there is no discussion. The patient recovers in the symptom in the evening of operation. And when I say in the evening of operation, all my residents are standing in front of me. And if one fellow says that I have not seen improvement, I will be very highly surprised. No question. The symptoms improve in the evening of operation by one operation, and that is atlantoaxial fixation. Syringomyelia will reduce in the long run in 100% patient. Tonsil going up can also go up in a huge number of patients, but I cannot give you the numbers in how many patients it goes up or down. So this is another case of syringomyelia and Chiari formation, and if you see the facets are in alignment, the atlantodental interval is not a problem, and this patient has undergone atlantoaxial fixation, and you see the syrinx size has reduced quite remarkably. Whether it reduces or not reduces, whether the syrinx comes down or not comes down, the issue is the patient recovers in symptom, and that is for sure. This is another case, Chiari formation, atlantoaxial facetal malalignment type 2 and fixation. This is another patient, syringomyelia, atlantoaxial dislocation, facetal malalignment type 2, where the facet of C1 is behind C2, and you see the size of syrinx reduced and the C1, C2 fixation. These are some more slides, pre-operative, post-operative. You see, you do atlantoaxial fixation and the size of syrinx reduces. Another case where the facets are in alignment, there is basilar invagination, atlantoaxial fixation, and the syringomyelia size reduces. So essentially, my article, which in 2014 we had published on the basis of 65 patients, now we have several hundred patients. Atlantoaxial instability is the cause of Chiari formation. Atlantoaxial instability is the cause of syringomyelia. Atlantoaxial instability is the cause of basilar invagination. Atlantoaxial instability is the cause of short neck and torticollis, is the cause of clipal file abnormality, is the cause of basilar invagination. We have also expanded our subject much beyond craniovertebral junction, where we are saying that atlantoaxial instability is the cause of cervical degeneration in a number of patients and other such conditions. Atlantoaxial stabilization is the treatment. When we wrote this article, there was a Pediatric Society of Craniovertebral Junction Society in US, which is a very big society of craniovertebral junction related to pediatric group. They said that this concept may not be suitable for children, may be suitable for adults, maybe this concept is suitable for patients having basilar invagination. So this article of ours had introduced a huge discussion in the world of neurosurgery, which is ongoing. And recently I was in one of the meetings in American Association of Neurological Surgery, and this article was being discussed in 3 sessions. So this is quite a subject to be discussed. And we wrote this article where we said that even in children, even in infants with Chiari formation, atlantoaxial instability is the cause and atlantoaxial stabilization is the treatment. And so this article is published in World Neurosurgery. Treatment of idiopathic syringomyelia. Nobody in the world knows how to treat, and nobody treats this problem. And if at all they treat, they introduce some shunts and all those things for syringomyelia. But we have said, no question, these patients should be treated by atlantoaxial stabilization, and it has the potential of remarkably improving the clinical symptoms of the patient. So this is one of the patients where there is syringomyelia. There is no Chiari malformation, there is no atlantoaxial problem, there is no instability of any kind, and you do atlantoaxial fixation, the syringomyelia reduces. Whether syringomyelia reduces or not, the patient remarkably recovers in the symptoms that we have seen. And we have seen in not one patient, we have not seen in 2 patients, we have seen in several patients, and some of these patients are lying in the ward even today. And even yesterday we have seen one patient with remarkable weakness of legs as a presenting symptom, and improvement in this symptom as well. So this is another case with basilar invagination, Chiari malformation, syringomyelia. I forgot to mention in my lecture that if you had seen carefully all these patients which I have shown, if you see the posterior cranial fossa, the posterior cranial fossa is quite lax. The subarachnoid spaces around the cerebellum are huge. There is no question of tight posterior cranial fossa. CSF spaces in front of the brainstem are huge. CSF spaces in front of the cerebellum, in front of the spinal cord are huge. There is no question. This is another case of syringomyelia, basilar invagination, Chiari formation. You see how the syringomyelia has reduced. I have now collected several patients, maybe about more than 30 or 35 patients, and I have recently written one article on the subject, where foramen magnum decompression surgery done earlier has failed. And if you read all the articles written in the literature about foramen magnum decompression, every article, if you summarize, on an average, there is a 25% failure rate following foramen magnum decompression. So 35 patients we have seen over the period where foramen magnum decompression has failed, and some of these patients had failed miserably and were devastated. And this patient which I am showing you, I am not sure if this is the patient. This patient was a radio singer, and she was unable to, following surgery, she had CSF leakage, and she was in the hospital for 1 month with various antibiotics in the intensive care unit, and then she recovered in that, but she lost her voice after surgery. This radio singer was not able to even talk properly. And these are the images of the patient, and we did atlantoaxial fixation, and I can tell you this patient is now back in radio singing after this fixation. We have not done any further manipulation to the foramen magnum. This is another patient, if you see, was done foramen magnum decompression, and you can see the syringostomy tube is there, subarachnoid tube, and the patient came in a devastated clinical condition. We did atlantoaxial fixation, and you see the syringe size has reduced. I'm again saying reduction of the syringe size is not the aim of my surgery, and I don't look for it. What I look for is the recovery of the patient, and there is no question this patient remarkably recovered in the symptoms. So essentially, basilar invagination, syringomyelia, Chiari formation, atlantoaxial instability is the cause. All these problems which are considered to be pathological phenomena, and I can tell you these, when I say that these were considered pathological, they are not, they are still considered pathological. Syringomyelia is considered pathological throughout the world, and that is why shunts are introduced. Syringomyelia is treated. Chiari malformation is considered to be pathological throughout the world. That is why foramen magnum decompression is done. That is why tonsillectomy is done. That is why dural decompression is done, because people think, or not people, but the entire world of neurosurgeons think that there is an intrusion in the foramen magnum by the tonsil. This is abnormal intrusion, and to increase the space, foramen magnum decompression is necessary. So we said that it is not abnormal, it is a nature's protective game which is meant to stall or delay the effects of instability. So we have said that foramen magnum decompression is not necessary because posterior fossa is not tight. On the other hand, anteroposterior length of posterior fossa increases, and anteroposterior length of the spinal canal increases. There can be CSF within the cord, which we call syringomyelia. There can be syringomyelia outside the cord. You see this slide carefully, and you will see that there is CSF outside the cord. We have labeled this outside syring as an external syringomyelia. So syringomyelia can be inside, syringomyelia can be outside, water can be inside, water can be outside. So this is a game of water. This is a game of soft tissues. When there is atlantoaxial instability and a potential of odontoid compressing the spinal cord, the whole spine changes, the whole craniovertebral junction changes in a protective mode. So we have done various measurements and various kinds of morphometric analysis, and we have identified it is not just that the neck becomes short. We have identified the head also becomes short. Head becomes anteroposteriorly long. The spinal canal becomes anteroposteriorly wide and vertically short. So there is a short neck, there is a short spine, there is a short head, and all these things are manifestations of one single problem, and that single problem is atlantoaxial instability. So you see in this slide, the posterior cranial fossa is not tight. There is a lot of CSF there. So there is external syringomyelia, external syringobulbia, which we have labeled these new terminologies. CSF can be present inside the cord, it can be present outside the cord. When it is present inside the cord, it is called syringomyelia. When it is present outside the cord, it is called external syringomyelia. When it is present inside the brainstem, it is called syringobulbia. When it is present outside the brainstem, it is called external syringobulbia. So these are the terminologies that we have introduced, and these have implications. These are huge implications. If you have a clear understanding of these problems, you can completely give a new brand life to the person without any question. Radiological demonstration of atlantoaxial instability or not, these are unstable problems, and these merit atlantoaxial stabilization. Short neck, torticollis, rotated, these kind of problems are external manifestations of atlantoaxial instability, like you can see them. Syringomyelia, Chiari malformation are neural manifestations of atlantoaxial instability. They are neural implications, a neural change in the formation of the entire story. So atlantoaxial instability is the cause of Chiari malformation. Atlantoaxial instability results in Chiari malformation. It is a protective, nature's airbag. In case of accident in the car, airbag comes in. In case of human being, there is a potential of accident or potential or manifest atlantoaxial instability which can completely devastate the spinal cord, tonsils herniate, or these are the natural airbag. So is Chiari a formation or a malformation? It is completely and entirely a formation. There is no question about malformation. It is not wrong formation. It is a divine formation. So foramen magnum decompression surgery become historical. I am absolutely convinced, and in my department, in my range, this operation is not done, and there is no question of doing foramen magnum decompression. Atlantoaxial instability should be understood properly. We should analyze and understand the nature's reparative games that happen when atlantoaxial instability happens. So treatment of basilar invagination, Chiari malformation, syringomyelia is atlantoaxial stabilization. Occipital fixation is not necessary. Foramen magnum decompression is counterproductive. Transoral, transnasal decompressive surgery are completely historical operations. Thank you very much, my dear friend.